Morning, everybody. I'm Olivia Fallbrook-Jones. I'm Deputy Director of Clinical Programmes and Delivery and Networks in normal times and co-chair of the Mental Health, Learning Disability and Autism Chair since COVID started. As we all know, both responding to COVID and restoring services has shown a light on inequalities and has increased the scale and pace of the actions required from the NHS and other sectors in tackling inequalities. In response to this, NHS England Improvement set up a task and finish group to consider inequalities, and they've identified 8 recommendations that we expect to be part of the phase 3 letter when it is eventually published. So today is very timely, and one of these 8 recommendations is about supporting those with mental health as well as physical health needs. And there are other recommendations that are obviously very relevant to our population groups with mental health, learning disability and or autism. So we've got a great panel of speakers today. As James said, the session will be recorded so that people can access it afterwards. What we will do is make sure that everybody is on mute. So if you have a question or a comment, please use the chat box if this is available to you, or the hand option again if this is available to you. Make sure you do come off mute, because we will mute everybody centrally apart from the speakers, and come on and off camera only if you are presenting or would like to ask a question. So over to Louis for our first presentation. Thank you.
Thanks very much. Is that showing for everybody?
Not at the moment, Louis. We can only see the participants.
Right.
Let me try and hold on. I need to stop sharing. That's why. So already a fail. Bear with me. So if you reshare now, Louis.
Okay. It works.
Here we go. I think it's coming up. Yeah, we got it.
Okay, fantastic. Welcome everybody. I am Policy Lead at Centre for Mental Health. We use a wide range of evidence, research and lived experience to influence policy and practice. We have a particular focus on addressing mental health inequalities, so I'm really pleased to talk through our recent research paper on mental health inequalities and coronavirus. This report actually comes from the combined efforts of more than 14 charities. As a whole, the voluntary sector has come together in the wake of the pandemic. We're trying to work together, collaborate more than ever. And the purpose of our report was to bring together emerging evidence, including research, survey evidence, live reporting from our partners who deliver services, and to use this to identify the groups most at risk in terms of poor mental health outcomes from coronavirus. This is still very much a live issue, so we haven't limited ourselves to the strict criteria for evidence you might see in a Cochrane-style systematic review. Rather, it's about a snapshot of where we are now and where we think efforts should be focused to target mental health inequalities. The report has supported our calls to government. We know it's helped local areas too in planning to address inequalities and develop business cases around mental health support during the recovery phase. So if I talk through in 4 parts, I'll give some context to mental health inequalities. I will highlight some urgent areas of concern kind of directly relating to lockdown and coronavirus. I'll discuss long-term considerations for people, services and inequalities, and then finish with some recommendations for action. So when pulling together this report, it felt helpful to visualise 2 overlapping groups of people who might experience an unequal impact on their mental health. So first, we've got those who are living with a mental health problem during the pandemic, that already manage complicated mental health problems, might be experiencing a more difficult time because of the pandemic. How have they been affected? And secondly, we've identified people who have certain characteristics or who are from certain communities where we think this means they could be having an unequally difficult time and therefore facing increased risks for poor mental health. These spheres do overlap. And when we think about vulnerability for the virus and poor mental health, again, there's an overlap. So the two spheres here show how the significant proportion of people with a mental health problem who also live with a long-term physical condition. Some of these long-term conditions put people at greater risk of COVID-19. So we're talking about an at-risk group here. And this diagram is based on estimates for all mental health problems. If we were to calculate and draw another Venn diagram based on more severe mental health problems, the proportion of those people with complex physical health issues would be larger. And to think about the that second broad group of people who might face an elevated risk of a mental health problem, there's plenty of evidence pre-COVID, if you like, about the risk factors for this. So there's just a small selection here: being poor, coming from a black or ethnic minority background, and being exposed to violence and abuse, especially for children and women. And these factors can play and overlap and accumulate from birth to older age. But to put it in a way that covers everybody, we are all on a spectrum from mentally healthy to unwell. So we're really thinking about who, as a result of coronavirus, is moving to the right, as we see it here, to the red, unwell stage. So we know that despite mental health services nominally staying open during the pandemic, as a result of lockdown and other factors, people with mental health problems have not been getting the same access to the help that they were before. In many areas, there's arguably already largely insufficient coverage. We know from an NHS England submission of evidence to the Health and Social Care Select Committee that national estimates were of 30 to 40% falls in referrals across adults and children's mental health services in March and April. Some local areas have been modelling up to a 30% increase in need as a result of suppressed demand during lockdown. And it makes people's mental health get worse. For people living with a mental illness, the loss of formal and informal support seems to be leading to an increase in more urgent appointments, more acute need. But it's important to think beyond mainstream services too. So many people find that mainstream offer unappealing or inaccessible for various reasons. They may normally present to peer support, to a community group to help them maintain good mental health. And not all of these groups and options have been functioning. There are worrying signs that many will continue to be unable to function due to a lack of funding. We should be concerned about the sustainability of these organisations because the tailored support delivered by the community in the community can be invaluable in giving people early access to help, especially groups who have traditionally faced mental health inequalities. So thinking about some black and ethnic minority communities who are experiencing really difficult times due to the prevalence of COVID locally, as well as the economic shock, these services that allow distress to be processed and support to be received outside of secondary services is critical. We know from figures from the CQC that for people with severe mental illness who have been detained under the Mental Health Act in hospitals or in the community, the mortality rate is double what it has been for the previous 4-year average. The picture of support arrangements for aftercare is quite blurry. So in terms of what help people getting on discharge from inpatient mental health care. Anecdotally, we've heard about people being discharged without care in place, about people unable to contact their care coordinators, and this risks those people then speedily returning to inpatient treatment. At the same time, restrictions on wards have meant that fewer people have had contact with family members or advocates while detained, which suggests that experiences could be worse both during inpatient care and when people are discharged into the community. So we'd really welcome more data and more insight into this area. Thinking back to the association between comorbid mental and physical health problems, this is a group of people where anxiety is still running high. So anxiety really peaked for the general population in the early stages of the pandemic, but it's kind of dropping. It's still higher than normal, but it's still very high for people who have comorbid mental and physical health problems. We know that people with these kind of complex needs can still be feeling vulnerable, and in many cases they are, still feeling the need to shield, and also they're missing out on support. And there are some surveys which do confirm this. There's been a lot of conversation during the course of the pandemic about the vulnerability of older adults. Not all of that discourse has been helpful. Some people have complained that there's an element of ageism in the early messaging. So in our report, we highlight how much more older adults could be impacted by grief, feelings of helplessness, the death of their peers, loneliness, isolation, and really worryingly, even accessing basic supplies. And we know that the older adult population is experiencing higher rates of anxiety compared to the general population, and are generally a poorly served group when it comes to mental health services. Before COVID, estimates were around 85% of older adults with common mental health problems went unsupported through a combination of diagnostic overshadowing, stigma, or fatalism about depression and anxiety being a natural part of aging. So during lockdown, evidence has emerged that suggests a rise in experiences of abuse and violence at home. We've seen calls to helplines rising significantly in the early stages. This means it's really necessary to provide safe spaces and trauma-informed approaches from now onwards, really, and thinking about those areas where those places where children might present with distress and where women might be able to be supported. The UCL social study, which reports weekly on a large survey sample, highlighted an important intersection between these experiences and families who are on lower incomes. And we know that low incomes itself is a risk factor for poor mental health, especially in children. So if those are the kind of immediate concerns, long term, we know that COVID has been a significant time of upheaval for health systems. We've heard from various places about crisis bringing systems together, and it feels like there's quite a lot to hold on to there. There have been some advances, particularly in digital and the rollout of 24/7 crisis lines, which have been really impressive, very speedy, and welcome for many people. But these need to be backed up. They need to be backed up by face-to-face support where that's more appropriate than digital, and crisis lines need to be followed up with access to haven or sanctuary style support and follow-up care. If this doesn't happen, we're concerned that this risks further excluding the most marginalised people who can't afford to get online, won't be able to develop therapeutic relationships remotely, don't want to receive help over video, or who need more than a phone call to help them work through acute distress. We're also aware that all transformation is underlined by investment, and we know that the long-term plan has made the financial picture of that quite clear, but we're also clear that we can't go back to austerity in any form as a result of the economic crisis that we're now in, and at the same time hope to address mental health inequalities. Investment to address mental health inequalities must also look holistically. It's got to look beyond supporting people through secondary mental health services in the NHS. It's got to look at public health, social care, social security, and community and voluntary organisations. And that economic impact is, it's looking fairly bleak at the moment. We're seeing a kind of accumulation of factors, including possibility of a no-deal Brexit, a winter flu, and the economic crisis, as well as any ongoing restrictions brought about to tackle the virus itself. Again, poverty is a major risk for poor mental health. Multiple surveys have shown that anxiety throughout the pandemic has been driven to a large part by finances, financial insecurity. And we know as well that poorest parts of the country have been hit worse by the virus itself. So people on low incomes are not only being hit harder, but we know from previous crises that they are the least able to bounce back from any disaster. So there's research from previous pandemics and also from things like flooding, any kind of local crisis, local disaster. It's the hardest, hits hardest for people on low incomes. Now, there's already a large body of work on the links between racism and poor mental health. We know that some Black and minority ethnic communities are persistently exposed to a range of risk factors for poor mental health. They have poorer access to services and often worse outcomes too. And many of these same communities are also experiencing higher mortality and greater rates of infection from COVID-19. This means more distress, more grief, more trauma. And at the same time, many of these people face the double disadvantage of deprivation and financial insecurity. It's really important here to bear in mind the concept of community trauma or community betrayal, which is where a perceived failure of the authorities which are meant to protect us can add to a second injury and reinforce that traumatic experience. So I'm conscious of time, so just to quickly summarise, mental health inequalities were stark before COVID-19. The pandemic has shone a light on them. Many people who already experience mental health problems or mental illness are likely to experience that getting worse, in part due to difficulties accessing the right kind of services for them. And then there are people in at-risk groups who are more likely to be pushed towards poorer mental health. So we're thinking about a greater severity of need and a greater number of people in need. And in this context, and in the context of future uncertainty, it's really important to ensure that support is there, that it can meet diverse needs, and that it's geared towards those most at risk. Our report made 11 recommendations. Most of these were targeted at government. So kind of looked at these again with a local health system lens, and we thought we would recommend six key areas. So targeting support at communities most exposed to COVID-19 and mental health inequalities, often the same groups of people. To fund and work with local community-based organisations to ensure that culturally appropriate support is available to people. To work with local authorities and other partners in the local health system to establish mental health equalities focus across the system. To embed trauma-informed approaches into all services and institutions. To commit to leaving no one behind during service transformation, especially when we're considering digital and all the benefits that could offer. And to prioritise race equality in mental health services, including by recording better data on equalities and offering transparent, open analysis of performance. I'm sure these slides can be shared around. It's just a selection of relevant publications from Centre for Mental Health. And if you have any questions about the research or want to get in touch about anything else, please do contact me directly.
Thank you, Louis, for setting the scene so well for us this morning. We will share the link to the recording and hopefully all the slides and a Q&A in the next week or so. It will take us a bit of time to get it together. James has indicated in the chat box, for those of you who have access to the chat box, to write your questions there. We do have a full agenda, so we'll take questions by exception, I guess, and we'll try to coordinate questions and then responses outside of the webinar today. So we'll circulate this separately. So unless there is one particularly salient questions for Louis, I will move us on to the next presenter. So I'll just wait a couple of seconds.
Yeah.
Okay.
Sorry.
No, that's okay, James. John, are you with us?
Yes, I am. Yeah.
Great. We're going to load your slides, or have you got your...
Yeah, let me share those now.
Thank you.
Hopefully you can see those.
Yes, perfectly. So you're going to talk about health inequalities in autism, as your main slide states. Thank you.
That's right. So my name's John. I'm the Chief Exec of Autistica, which is the UK's autism research charity. We are the biggest independent funders of autism research in Europe. And we work very closely with your colleagues nationally and a lot of your colleagues locally as well, advising on autism issues. The main area that I'm going to focus on today is specifically around autism, but of course autism intersects with a really significant number of other neurodevelopmental conditions. So as we go through, there'll be various points where I might pull out particular aspects that pertain more to autistic people, for example, with a learning disability, or autistic people with ADHD. But the common thread that we'll run through it is obviously primarily around autism. So if we put COVID to one side, we do have a really significant body of evidence already which demonstrates the very significant health inequalities faced by autistic people. The first paper I'm referencing here, which is from 2016, is a Swedish population-based study which showed significantly elevated mortality for virtually every single cause of death. Infection is the only one where we didn't see a significant increase, which is probably to do with the social behaviour of autistic people and slightly lower exposure to infection risk. But for virtually everything else, whether that's cancer, heart disease, respiratory conditions, neurological conditions, there's a very, very significant increased risk of premature death. And that cuts across the IQ range. So that is true both in those who have a learning disability and those who don't, although the relative risks do tend to vary quite significantly. Off the back of that paper, which did receive a very significant amount of attention from policymakers and professionals and charities when it came out, a number of other studies have been done, both using UK data and other large data sets, which have both shown that Swedish study was broadly correct in every setting where it's ever been examined. So the statistics broadly stand up whether you're using UK, US, Canadian, European data. There definitely is a significant mortality risk. But a number of subsequent studies have looked at slightly different slices of the population. So some have looked, for example, at young adults or children. Some have looked at women or men. And broadly, the same story, depressingly, is true, sort of regardless of the other demographics we're considering. There's a very significant number of physical and mental health inequalities. I won't sort of talk to each of those papers, but there are links to all of them on the slide if you want to read up further on that. And I would say this is an area where we're still seeing more and more reports coming through, more and more papers being published, which essentially just demonstrate again and again the significant challenge that we face. So if we then look to the reasons that underpin those health inequalities, this is not by any means an exhaustive list, but I thought it might be useful in the context of the following slide, which is looking at COVID specifically. It might be useful to understand what we know of the underlying factors that we think lead to that significant inequality. The first is biological. So it's well recognised that autistic people have predisposition to some physical and mental health issues. We don't necessarily fully understand the mechanisms of that, but it's certainly well recognised, for example, that for someone who's autistic and has a learning disability, they're at very, very high risk of also having epilepsy. That doesn't necessarily mean they're always diagnosed and treated effectively, but we certainly know that risk is there. We know there are very high rates of gastrointestinal issues, and we know that for virtually all autistic people, anxiety is often a lifelong companion to their autism. And there is increasing evidence of different responses, both to pharmaceuticals, but also to behavioural therapy. So for reasons, again, that aren't fully understood, autistic people respond less positively to drugs and they respond less positively to typical behavioural therapies. We do have good evidence now that adapting behavioural therapies in particular for autistic needs does tend to lead to to higher effectiveness, but I think that's still an area where there's an awful lot of research and potentially changes in practice that are needed. There's then the societal challenges. So it's just very, very hard to be autistic in a world which isn't very friendly to autistic people. And that, unsurprisingly, leads to very high levels of depression and anxiety, very elevated levels of things like self-harm and suicidality. On top of that, autistic autistic people are more likely to be poor. The employment rate, for example, amongst autistic people is thought to be somewhere in the region of 16 to 20%, so one of the highest unemployment rates of any disability. Autistic people, although this does vary wildly, autistic people are more likely to have low educational attainment, and even in cases where people have an awful lot of qualifications, so people with multiple PhDs, for example, they're often actually still highly unlikely to be in work. And autistic people are very likely to be in contact with the criminal justice system, both as victims and perpetrators. If we then look at the intersectionality with gender and with race, there are well-recognised misdiagnosis issues there. So particularly children, particularly black children and some Asian children are more likely to be diagnosed with conduct disorders than they are with autism. And then only later will they receive a correct autism diagnosis. And we have recognised issues with many of the diagnostic tools, which are not as accurate picking up the presentation of autism in females. We are getting slightly better, I think, at picking up autistic girls and women, but we know that there is a much longer delay until diagnosis in that particular group. We've then got structural challenges with the way that we deliver healthcare, many of which have been recognised and are being tackled at sort of national and regional level. One is the lack of reasonable adjustments that allow autistic people to both access and participate in healthcare. The sensory challenges that come with healthcare environments. I hear almost on a daily basis issues from autistic people and family members saying that they simply can't use their GP surgery because the waiting room is such a sort of difficult environment from a sensory perspective. The same with hospital environments, A&E, that sort of thing. Communication challenges, you'll spot if you're looking closely at these slides, communication challenges appears twice. In this case, what I mean is the challenge of healthcare professionals not necessarily knowing how to communicate effectively with an autistic person. I think one of the things we spend a lot of time focusing on is trying to get people to appreciate that although autism, it has elements within it of being a communication, people having differences in their communication style, actually that's a two-way street. And any dialogue that you're having with someone, there are communication challenges on both sides, what's often known as the double empathy problem, and a distinct lack of awareness and training across the healthcare service, where lots and lots of healthcare professionals simply do not know how to deal with an autistic person that presents to them, wouldn't know how to spot a likely undiagnosed autistic person sitting in front of them, and therefore aren't able to change the way that they behave or the therapies that they offer. And then within the personal dimension, lots of autistic people have alexithymia, so they really struggle to link their physical or emotional state and their mental states. They may be highly anxious, and it's obvious to everybody around them that they're experiencing incredibly high anxiety, but they themselves are unaware that that's what they're going through. The communication challenges, as I said before, that people may struggle to get their point across to a doctor. They may struggle to articulate a problem in a way that a doctor is going to interpret properly. And often they've had very, very poor prior experiences in lots and lots of settings, but I guess for this conversation today, particularly in healthcare settings, which lead them to be very avoidant, which lead them to present late with both physical and mental health issues, and lead to challenges in terms of building rapport with therapists and professionals. So when we look at the COVID impact specifically for autistic people, it's relatively challenging from the data that we have to understand whether or not autistic people specifically are at higher risk of being infected and dying from COVID-19. The data we do have suggests a higher risk for people with learning disabilities, but the data quality, which has always been an issue, doesn't allow us to cut that data and understand whether people who are only autistic, i.e. autistic and in the typical intellectual range, are at higher risk. We simply don't know. The mental health impact specifically, I think it's fair to say, has been mixed. We have heard of some people who said that they've actually found lockdown a very positive experience. They've thrived without the social pressure that they felt in typical times. They've been able to stay in a familiar home environment. They've been able to maintain particular routines that they find comforting and protective. But on the flip side, many, many others have found the uncertainty of the situation really incredibly difficult. They've found that changes to their routine, because they've not been able to visit particular favoured places or they've not been able to do certain activities, they found that very hard. Many people have spoken about the issue of accessing in particular favoured foods and brands in supermarkets. Autism being an invisible disability means that lots of people didn't feel able to access those environments or physically weren't able to access those environments. And the issue of unclear guidance has come up again and again. Autistic people stereotypically are often quite rule bound. I think the reality is they certainly find it very confusing when guidance is issued which then isn't followed by the broader population, or when guidance is issued which is ambiguous. And we again and again have worked with colleagues across the autism sector to try and ensure that when guidance is issued, it's available in a format that everybody can understand, but it is also not ambiguous and doesn't use a sort of language that autistic people might struggle to interpret. Anecdotally, we are hearing from services of fairly worrying increases in self-harm and suicide, and there have been a number of media reports around that. At this stage, I would say I don't think we've got strong data to back that up, but certainly what we're seeing from the reports that we hear and the reports that we're getting from services is that for those who are already struggling, there have been a number of sort of marked increases in self-harm and suicidality. We are quite concerned that for an awful lot of autistic people, those who struggled and those who didn't in lockdown, coming out of lockdown actually may be harder than going into it, because it will be a staggered process. Change is inherent in that process of moving out of lockdown, and indeed there will start to be local variation. So it will simply be harder to sort of get your head around what the situation is. But crucially, and I'm not sure this has been talked about a great deal, lots and lots of people on the spectrum use coping strategies and have built up resilience which allows them to operate within society, but those things require practice. And certainly speaking purely to the autistic people who work for me, many of them are very, very concerned that they really haven't had to deploy many of those coping strategies. And they're quite concerned that as a result, their ability to, for example, travel again on public transport, to go back into an office or a workplace setting will be very, very difficult, because they haven't been sort of keeping those skills honed during the period of lockdown. We are hearing from lots of autistic people and families, and this applies across the age range, that people are struggling to access mental health services in particular. I know an awful lot of work has gone on to make sure those services are available as much as they possibly can be, but it certainly doesn't seem to be the case from the people that we talk to, that they are successfully able to access those when they're in need. We are I guess, interested / concerned about the move to a much greater level of virtual or digital delivery. Certainly it's the case that for some autistic people, having virtual health appointments is a real positive. They're able to stay in a familiar environment. They don't have to visit that environment that from a sensory perspective may be very challenging for them. But on the flip side, many other people are talking about how challenging it is to in some cases technologically to access those things, and in other cases to build rapport with a professional and get their points across. And we are concerned about the near total lack of evidence for effectiveness, acceptability and cost effectiveness when it comes to using digital solutions with autistic people. A number of reviews have come out literally in the last few days which have shown exactly that we just don't know whether or not they do work, we don't know for whom they work, and we don't know how we optimize those things to make sure that they are inclusive and effective for autistic people. So that's something that we as a research organisation are hoping we can begin to plug the gap. And many people do fear being forgotten as we return to some sort of normality. I think there's a real sense that autistic people were not prioritised before all of this happened. There have been long-standing issues for decades, for example, with delays in diagnosis, people presenting late with all sorts of issues, physical and mental, and then not receiving appropriate care. I think people's fear is that if things were bad before and now the health service is under even more pressure, the greatest likelihood is that they will be left behind yet again. Obviously, we and partners are doing everything we can to make sure that doesn't happen, and doing our best to reassure our beneficiaries as well. But I think that's an understandable fear that many of them are experiencing. I think that is my final slide. I'm very happy to talk more to any of those points, and indeed to share the evidence I put in these slides and other papers that we've got if people would find that useful.
Thank you very much, John. Just a question, I guess. There's a few comments in the chat box about children and young people seemingly being more affected through the last few months. Is that something that
as opposed to adults? I mean, I definitely would say that's true. I think, young autistic people definitely seem to have struggled more than young people generally. I don't know that that's an age effect in any way. I think we're hearing the same from older adults, for example. I think all autistic people, I think there's a portion of all autistic people of all ages who have struggled. I think there is some data that's come out literally today that I was hoping to read before this presentation that I didn't manage to get to, which is looking specifically at the experiences of autistic young people. And from the abstract that I read, it did strongly suggest an increase in mood disorder, conduct disorder, and a decrease in prosocial behaviour, which we sort of would have expected to see. But I guess this stands that up fairly well, and it was a pretty large-scale survey, so I think that's certainly indicative. I think we would have expected before any of this happened that this would be a group who would struggle in this sort of situation. So in a sense, I think our fears have been borne out rather than telling us something we didn't already know. I certainly think we have a major concern at the severe end. Those who were already experiencing severe distress do seem to have got markedly worse and do seem to still be struggling to access services. I can look more into that for you, and if there's maybe I can sort of do you a quick summary of papers, because there are quite a flurry have come through in the last couple of weeks.
All right, thank you very much, and you've got a few interested people in contacting you outside of this, so
very happy to do that.
Thank you very much, John. Shall we move on to Rachel and the leader review and the review? James?
Sorry. Yes, sorry, Olivia. Didn't mean to jump on there.
That's okay.
Rachel sadly is not available this morning, but we do have Dr. Pauline Heslop on the line, hopefully. And I have the slides as well, in case you, Dr. Heslop, are happy to take the reins on the presentation, or I can actually forward them on for you if you're available. Oh, you may be on mute, Pauline, I don't know.
Would you like to load the slides, James?
Sure, I can get them up.
Thank you.
I can't check the participant.
I'm doing that right now.
Oh, hold on, I think I just had a...
So we've got the slides currently.
Yes, but I'm not sure whether Pauline is...
Hi.
Oh, she is.
Sorry,
Hello.
I've just joined you. I'm so sorry I'm late.
That's okay, just in time.
Good.
Pauline, I can go through the slides if you'd like, or if you'd like to take control. I can run through if you just sort of give me a nod and I can move us through.
Okay, yes, that's fine then. Okay.
Thank you.
So, so the first slide then. So the next slide. So this is a summary of the first 50 completed reviews that have been received by the University of Bristol for the analysis. It's not a representative sample, so we must remember that. If you could go on to the next slide. Shall I?
Sorry. Oh, hold on, Pauline. Yes, I can give you access to that. There you go. There you go.
Sorry, I'm not able to move them on. Sorry.
Okay, let me go back. Sorry about this, everybody. This is all my. Let me I will share my screen now. Go to. Stop sharing. Here we go. Here we go. Right, we're there. Hopefully.
Okay, perfect. Thank you.
And go to the next, yeah?
No, so the previous slide.
Sorry.
Is perfect. Thank you. Okay, so it's not a representative sample. It's just the first 50 that have been received. So it's overrepresented for the Midlands and London. Underrepresented across the country. It's overrepresented for people aged 50 to 74 years, which may actually be an indicator of early deaths of people from people with learning disabilities from COVID as compared to the general population. It's overrepresented people from Black, Asian and minority ethnic groups, which may be to do with the fact that this is the Midlands and the London areas predominantly, but it also echoes what we know from the general population. And 15 of the 50 people had Down syndrome. We're not quite sure of the significance of that yet, and as to whether Down syndrome may be an indicator of increased risk of death from COVID-19. Okay, so the next slide. Almost all of the people who died. So next slide.
Sorry, yeah, sorry about this. I'm trying to get through. I apologise. It moved me through. There we go.
Perfect. Thank
Sorry
you.
about that.
So almost all of the 50 had 2 or more long-term health conditions. I've put on this slide, you can see the most commonly reported, but there's a couple that I'd like to point out really. So the first is mobility impairment, which was 32 of the 50, and mental health needs, which was 17 of the 50. Now, those are not recognised pre-existing long-term health conditions that are noted to be risk factors in the general population. And they might indicate that people need regular and sustained contact with other people, which may place them more at risk. Or it may be that decisions to treat people are being based on these existing impairments, of which we would need to take note. And then the other pre-existing long-term health condition I want to point out to you is epilepsy, of which 18 of the 50 died who had epilepsy. Again, this isn't a recognised long-term health condition, but I think we need to be aware of it in people with learning disabilities as a potential risk factor. And then the other conditions on the screen are well-known risk factors relating to the general population, so hypertension, obesity, dementia, pre-existing respiratory conditions and diabetes. Okay, so the next slide. I'm just going to go through the symptoms of COVID-19 that people with learning disabilities had. Of note is that 43 out of the 50 had 1 or more of difficulty breathing, cough or fever, and only half had 2 or more of those 3 symptoms. But you would need to note that fewer than 10 people had all 3 symptoms and fewer than 10 people had none of those symptoms. Nobody reported having an altered sense of taste or smell, but in people with learning disabilities, loss of appetite may be a better indicator of that. But it was indicated in fewer than 10 people, as were being generally unwell, having lethargy or tiredness, having diarrhea or vomiting, or importantly having recent urine or chest infections, which again I think we need to be more alert about. Okay, next slide. In terms of circumstances leading to death, almost all of these completed reviews, the deaths occurred in hospital. Of note is that 39 had a do not attempt cardiopulmonary resuscitation decision made and recorded, and that's higher than we would usually expect with leader reviews. 23 of the 50 had a steady deterioration leading to death, but it's important to note that 13 had an apparent stabilisation or appeared to be getting better from COVID-19 and then had a subsequent rapid deterioration and died. It's also of note that 10 of the 50 had been readmitted to hospital after a previous inpatient stay, which was of concern. Most of those were readmitted to hospital for a different reason. Readmitted due to COVID, which was different from their earlier hospital admission. And then 13 had indicated concerns or problems with the person's care, which again is much higher proportion than we would usually expect to see in leader reviews. And those concerns were predominantly with a lack of personal protective equipment being used, concerns about decision making, particularly in relation to ceilings of care or treatment for the person, and concerns about the promptness with which medical attention was given to people. The next slide, please. So we drew 6 conclusions from this small study. The first is that mobility impairments and or mental health needs may be proxy indicators that people are at risk of catching the virus, or they may underpin prejudicial attitudes towards care treatment and judgments about ceilings of care. The second is that it would seem appropriate to consider people with learning disabilities and epilepsy as being at increased risk and pay attention to protecting them. And then the third is that the key symptoms of COVID in the general population may not be as apparent in people with learning disabilities, particularly the loss of sense of smell or taste. The next slide, please. The fourth conclusion we drew is that the use of DNA CPR decisions and the initiation of palliative or end-of-life care should be monitored to ensure that the population isn't disadvantaged. The fifth conclusion is that close attention needs to be paid to the safe and appropriate hospital discharge planning. I've already mentioned that there was a very high proportion of people who'd previously been discharged from hospital only to be readmitted again soon afterwards. And then our final conclusion is that additional resourcing for specialist learning disability staffing and expertise in primary and secondary care does seem to be indicated from the findings here. We have 13 out of 50 of the completed reviews that indicated concerns over care and treatment related to COVID-19. And we know that people with learning disabilities may be unable to advocate effectively for themselves, but it seems that carers were also unable to effectively advocate in some circumstances for some people with learning disabilities. We also know that communication with or by people with learning disabilities may not be so easy to understand for people, particularly when a person is in hospital on their own without much support, without their known supports. And we also know that people have diminished social networks with so many social care settings closed, and yet actually people with learning disabilities need enhanced rather than diminished support at this particular time. So that's all I've got to say for those 50 reviews. Very happy to answer any questions anyone might have.
Hello, Pauline. There are a few comments here. Thank you. Very helpful, I guess, initial conclusions, but very sobering as well. So we've got a very practical question about, have you got a range of days or weeks in terms of the readmission between the initial condition and then the COVID admission? So I haven't at my fingertips. We could go back to it, but it's not always included in the completed review documentation. It was more often mentioned that a person had been readmitted rather than the number of days or weeks, but we could certainly look and see what we have for those cases, yes. All right, thank you. And then there's almost like a case study from Anthony Shannon in Southampton saying, we saw a higher number of deaths in our care home sector, which were aspiration pneumonia diagnosis without consideration of COVID-19. Is there a possibility of the same occurring in the learning disability community when the death has occurred? I think, yes, we've had a so the 50 completed reviews were deaths that had COVID-19 included on a cause of death certificate. Not all of them had been tested positive for COVID, but the death was assumed to be related to COVID. But what we also know from the notification of deaths to LEADER is that we have had a substantially increased number of
deaths notified to us during the COVID period that have not identified that the death was due to COVID. So as in the general population, which has seen an increase in what's described as excess deaths, I would prefer to describe it as an increased number of deaths. So too, we found that in people with learning disabilities. I think without widespread testing, some of those may have been related to COVID, either directly or indirectly. So indirectly, it may be that hospital appointments have been cancelled. People haven't liked to trouble a GP. People haven't liked to go out and visit appointments for proactive healthcare in the same way that they might have done usually, and that might have had knock-on effects.
Okay, thank you. Anthony, did you want to follow up? You've come up on screen. Thank
you very much for that response, Pauline. I'm in that unique position that my main role is infection control lead for the city. So, and I'm also the LAC for the LEDA programme here. So I have that dual look at what's going on with the deaths. And we've had some very serious alarms where we've had 14 to 12, 14, 16 deaths occurring in large nursing homes where aspiration pneumonia was the main cause of death. At the same time, COVID was being circulating and nobody was considering it. And the deaths that we've had in our LD community here, which hasn't been substantial, we've had 6 confirmed C19 deaths. In 3 of them, aspiration pneumonia has been the significant diagnosis. So I was just concerned. It was really alarming to see some of the data that you were getting out from that very small, it is only a very small early study, that we have deaths occurring that are getting missed pure and simply because it was quicker to put down an aspiration pneumonia rather than actual, was it COVID related?
Yeah.
Well, thank you for what you've done anyway.
I think it will be important to analyse all deaths during the COVID period, not just those deaths from COVID, exactly for the reasons that you're giving.
Thank you. And then just as a final comment, there's a discussion in the chat around the role or access to the learning disability liaison nurses in the acute and the insight they might have in some of the care or gaps in care, which might be interested in pulling into your analysis as well. Yeah. So thank you very much, Pauline.
Okay, thank you.
We'll move on now to colleagues from Slough, and is Joanna on the
Yes, I'm here, Olivia. Hi. I think I need to request control so that I can present my slides. I'm just going to have a go at doing that.
It's looking good, Joe. It's James here.
Great. Lovely.
Yes.
I'll just turn it to slideshow view now.
Perfect.
How is that looking?
We're there. We're good.
Is that
yes?
Fantastic. I'll start. So hi everyone. My name is Jo Rowlings. I'm a clinical service manager and senior CBT therapist with Talking Therapies, and improving access to psychological therapist service covering East and West Berkshire. My role is Berkshire-wide, but my clinical practice, pre-COVID that is based in Slough at a community hospital in the town centre and at a GP surgery. I usually work face-to-face, but now deliver all my clinical sessions remotely via video consultations. I've recently started my drop-in clinic via video, which I'll tell you about later. I'm here today to tell you about a project which started in 2014 and is still continuing in a business as usual approach. This project was set up to improve access to the BAME population in Slough, and secondly, to improve recovery from common mental health problems. It's important to note that BAME is a term that covers a wide range of people with a very different, diverse range of needs. different ethnic groups have different experiences of mental health problems that reflect their culture and context. Let me first tell you about Slough. What you may not know is that Slough has more corporate headquarters than Scotland, Wales and Northern Ireland put together. It has a strong manufacturing base, as well as one of the highest business startup rates in the country, with productivity now top in the UK. However, there remain pockets of deprivation and inequality in the town, including financial, health and housing inequality, in particular when compared to the neighbouring areas of Windsor and Eton, Maidenhead, Ascot, Burnham and Taplow. In terms of deprivation, Slough is ranked 78th out of 152 local authorities in England, where a ranking of 1 is the most deprived. The most recent UK census produced the following figures for the Slough population. BAME 54.3%, White British 34.5%, and 11.2% white other, including a sizable Polish community. Slough is also characterised by having high levels of refugees and asylum seekers, many in need of services but difficult to reach, mainly from Somalia, Syria and Afghanistan, with over 40 countries represented. And 15.5% of households in Slough are without English as their main language. Here are some recent headlines. And this is the Labour MP for Slough, Tam Desi, calling for action in a social media post in May, following reports of the BAME community being disproportionately affected by COVID-19. These are well known to us now as more data has been produced. The second quote is from The Guardian, also in May this year. And the third quote is from the new president of the Royal College of Psychiatrists, Dr. Adrian James, in June of this year. And he says that people from a BAME background face a triple whammy of blows to their mental health due to suffering disproportionately from COVID-19, the despair and hurt many people feel following the killing of George Floyd, and the ongoing institutional racism in the NHS. So huge challenges in prospect for those working in mental health. And we're going to have a look at these in the context of IAPT services now. So recent data included in the IAPT BAME Positive Practice Guide of 2019 suggests that compared to people from white backgrounds, people from most BAME communities are less likely to use IAPT services, less likely to complete treatment, less likely to reliably improve, and less likely to achieve full recovery. So let's talk about the Slough Improving Access project. So when I joined the team in 2014, the referrals into our well-established IAPT service, which started in 2008, did not reflect the diverse population of Slough. Despite us being based in one of the most deprived areas of Slough, linking in with GP surgeries and service users being able to self-refer via our website or text or phone. The second challenge was to improve access to psychological therapies for a diverse population while taking account of complex presentations, a high incidence of trauma and PTSD, and a higher than average incidence of deprivation. And thirdly, recovery rates were below the national target of 50%. And other challenges included the need for interpreters and practitioners delivering psychological therapies in languages other than English. The Slough Access project was set up with two main goals. Firstly, to increase referrals from BAME service users, GPs and other key stakeholders. Secondly, to develop excellent relationships with GPs, CCGs, faith and community groups, and other stakeholders to increase the profile of the service. Other expected benefits were an increased awareness and understanding of how to access the service by Slough residents, increased involvement of the IAP team in the local community, and a better understanding of service users' needs. And finally, a focus on quality and improving recovery rates for Slough service users. What we did a lot. It's challenging to summarise everything we did here, but there were 5 key areas. So to begin with, we researched local communities and identified barriers to referrals. The barriers to referral included non-English speaking service users, perceived stigma and shame amongst the faith communities if family members access mental health services, lack of understanding of the evidence base for talking therapies, preference for the medical model, medication seen as being more effective than talking, and some GP surgeries did everything in-house and had very low referral rates into our service. Secondly, we gathered feedback and increased engagement through patient forums. So patients who had accessed talking therapies were able to inform the service about possible barriers. So this was more of an in-reach. We also increased awareness and referrals by developing strong relationships with key stakeholders, including health and social care professionals, third sector and faith and community groups. Delivery of the project began with contact by phone or in person with all GP surgeries to strengthen relationships, to find out what was working and what could be improved. And these discussions led to the provision of GP surgery drop-in clinics by talking therapist staff. So GPs can book in their patients who may struggle to engage with IAPT in the usual ways. And talking therapist staff welcome them to the service, identify their presenting problems and book them a wellbeing assessment. Fourthly, we recruited staff who reflected the diversity of the Slough population. This was incredibly helpful for conducting assessments and treatment sessions in service users' own languages and for developing culturally sensitive practice. Most widely spoken languages in Slough are Punjabi, Urdu and Polish, and there is some demand for other Asian languages including Hindi, Farsi and Arabic, as well as some African and other Eastern European languages. Along with this, we provided culturally sensitive supervision and specialist supervision for therapists delivering therapy in other languages. Fifthly, we did loads of outreach. We set up information stands in supermarkets, shopping centres, libraries, GP surgeries, community hospitals. We gave talks at business breakfast seminars, delivered stress-less courses in sixth forms and colleges. We had adverts in local papers and on radio stations, set up an Urdu and Punjabi diabetes course. We produced leaflets and audio recordings in different languages and many other activities. And to monitor our effectiveness with all these activities, we had a project team that met monthly to review and plan activity against key performance indicators. And this graph shows the outcome and the progress that we made from the start of the project. So this shows the percentage of BAME residents who accessed Slough Access from 2012-13 through to 2018-19, compared with those of a white ethnicity and those whose ethnicity was missing from the data. So the graph demonstrates a steady increase in BAME access. So BAME access is the blue part of the bar chart, and you can see that it gradually increases from the start through, although there is a slight dip from 2017-18 to 2018-2019. Additionally, it shows an increase in overall recovery rate, which was 45% in 2012-13, and it now has an average of 55% over 3 financial years, 2017 through to 2020, although that's not actually shown on the graph. Since then, our access has stayed steady at 50%. So this is slightly below the census figure of 54.3% BAME in the Slough population. So there is still room for growth and development. The project has continued, but it's more business as usual, and it includes a BAME lead role for one of our therapists. We are working within the BAME positive practice guidelines, as mentioned previously. And we now have therapists linked to all GP surgeries who are responsible for developing relationships and running drop-in clinics. What made a difference? So I've thought really long and hard about this to try and make it seem real and not just a list of things that we did. So I think it's really important to recognise that it takes time and needs consistency of personnel, energy, commitment, flexibility and enthusiasm to build good relationships founded on mutual trust and understanding. We were lucky to have a wonderful team of staff who reflected the diversity of ethnicities and languages in Slough, including one member of staff in the photo during a team charity 5K last summer. I used to love walking into our contact centre and hearing all the assessments taking place in languages ranging from Urdu and Punjabi to Polish, French and Arabic, usually with a smattering of English words thrown in when there was no equivalent in the other language. Data was crucial. So our wonderful data leads produce monthly BAME access data, did a breakdown by GP surgeries, read their access, and ran reports on recovery and reliable improvement rates. Our Stress Less courses were really successful. They took place in adult settings and also in sixth forms and colleges. These are mainstream educational workshops which normalise mental health problems and help to get young people talking to each other, their parents and teachers about stress and mental health. And finally, we had a very supportive and responsive comms team who produce high quality leaflets, posters. They update our website and organise promotional events, workshops and conferences, and we couldn't have done it without them. So thank you all for listening, and please let me know if you have any questions.
We have a couple of questions for you, Jo. So if I start with Sarah's question about the inclusion of BAME groups in preparing this presentation.
Oh, that's really interesting. Yes, I am aware that I'm a white British female in delivering this presentation. Yes, so I consulted with Slough colleagues in preparing the presentation. So one of them, Pramjit, is our BAME lead for the service, and another one, Rani, does a lot of outreach and inreach, primarily in children's centres and with health visitors. So those were the main two people I consulted with in preparing this.
Thank you very much for your response. And Nadia has pointed out that the Trust leadership has been really supportive of this work as well, and worked really hard to provide that outreach support to the communities.
Absolutely, yes.
And there's a question from Anne around GP practices and the type of offering from the IAPT service to each one of the GP practices, depending on the practice population.
Yes, so we have around about 20 GP practices. When we started the project, we had 22, but I think we might have got slightly fewer now. So in terms of the offering from our IAP service to each GP practice, so pre-COVID, when it was possible to do face-to-face work, we tried to access space, clinical space in the GP surgeries. And for those surgeries who were able to offer us clinical space, even if it was only half a day per week or a day a week, it meant that we could actually be there. And obviously that was very helpful in getting to know the staff and building relationships. And it also meant that for those of us who have been able to run drop-in clinics, the GPs could book in patients at really short notice for a half an hour slot, and we'd be able to meet those patients and just talk to them about what talking therapies might mean and if it would be helpful for them, and then book them in a more in-depth assessment very quickly. So for the patients, the process would be relatively quick and quite seamless. And we're also there for consultation as well. So if GPs have questions about mental health, the presentation of their patients' difficulties that they're coming up against, we can be there and give them quick consultation rather than having to phone us up after their surgeries.
Thank you very much, Jo. We'll take a question offline around the helpfulness or unhelpfulness of the term BAME, if you don't mind.
Yes, of course. No problem.
And just in the interest of time, I know that John has joined us. So have you got your presentation, or does James need to load your slides, Jono?
No, I'm being sneaky and speaking completely offhand from the centre.
Oh.
Yeah, if there was auditable trace, I'd get in trouble, but I just wanted to sort of take this opportunity to firstly say thank you for inviting me, and secondly to give you a very sort of honest and open update on what's happening on the equalities front from mental health from sort of the NHS England side of things. And the camera's on. So I think that was a really fantastic presentation, because I think it sort of outlines that in the current state of play, especially with COVID and with Black Lives Matter, I think equalities and advancing equalities is front of people's mind. And we do currently have some tools available to us, whether that's the IAPT BAME Positive Practice Guide or the sort of newly promoted and upgraded fingertips profile from Public Health England. I think our most immediate focus right now is sort of pushing the tools that are out there and using them to their best advantage. So I think, again, just being candid with everyone on the line, you'll be aware that the NHS as a whole is looking at COVID recovery as a priority. And I can say that there will be a letter going out probably this week or next week that outlines what phase 3 of the recovery process looks like. And we can all expect that equalities will feature quite heavily on that. And that for mental health, the ask is very much about using the data that's already available to inform recovery planning and efforts, especially data that's collected in the IAPT dataset, because we know it's of a sufficient and robust quality to drill down into different ethnic categories and age groups and things like that. So I think everyone on the line can expect that that will come probably this week or next week, fingers crossed. I also wanted to flag in advance that following that letter, there will be a second letter from Claire Murdoch here at NHS England in Improvement that itemises all of the deliverables in the long-term plan for 2021 and against each of them, whether that's increasing access to perinatal mental health services or IAP services, identify some opportunities to advance mental health equalities against each of these ambitions. And we're hoping that that will be a sort of a helpful reference point for all sort of ICS leads and providers in thinking about what they can do practically to advance equalities and to really sort of capture the sentiment of the nation right now, which is just about doing better, especially for Black communities and Asian communities, older people, and other groups that have been disproportionately affected by COVID. And again, please don't share this too much widely, but we are also currently seeking permission to publish a much more comprehensive multi-year strategy, which outlines some of the national and regional support offers to advance equalities in mental health. We know that right now the focus is very short term about the sort of quick wins wherever they're available, but everyone on the line can attest that when it comes to advancing equalities, it is so messy and systemic that it's very difficult to achieve quick wins. But what we want to do is provide a bit more sort of a longer term direction on what we're going to do, especially as a sort of central organisation to support advancements in access and care for people with mental health problems, regardless of their protected characteristics or whether they fall into a different health inclusion group. So what I'm going to do really quickly is just rattle you through some of the things that you can expect to see in this strategy should it go ahead. And I think the first one that's front of mind for us right now is the Patient and Carers Race Equality Framework. So those of you who will have read the Mental Health Act review, one of the recommendations was for NHS England in Improvement to develop what's called an organisational competency development tool for trusts that has a focus on improving the experience of care for ethnic minority groups, especially for Black British groups who we know fare worse than others in mental health services, especially at the severe end of the spectrum. So we have recently mobilised a steering group to help us shape that. That's got lots of patient and carer reps, which is fantastic. And we've been working closely with a number of different trusts across the country to pull that together to shape that tool. So over the next year, our focus is very much on developing that and coming up with a product that will be tested in a few areas across the country. And our commitment this year is that we know that there's plenty of evidence on where inequalities exist, but we know that there is not a lot of evidence of how you can overcome things that are so tricky and complex. So when we do get some evidence from the PCREF pilot sites, our aim is to share those as soon as we can to encourage sort of like a collective effort to just improve the experiences of Black, Asian and minority ethnic groups in NHS care. So secondly, many people on the line will be aware that in mental health, with the long-term plan, we got an unprecedented level of investment, and a lot of that is tied to sort of transformational activity. So our commitment this year and going forward is that any transformation pilot site that's either been selected or that will be selected in the future for things like mental health support teams or crisis or whatever it may be, that all of those have an explicit focus on equalities, and that's a condition of receiving funding and trying new things. And again, we're trying to use that as a bit of a lever to address the pretty shocking gap in evidence on how you can actually overcome these long-term systemic inequalities for groups with protected characteristics in particular. So our commitment this year is to work with those pilot sites and to gather whatever early indicative evidence that they've got so that we can collectively share that and lift each other up to do better in the equality space. I think I've just got the draft in front of me, which I can't share, but I can say that we're also looking into provider collaboratives, and without going into too much detail, I think everyone on the line will be aware that they have incredible potential to do more in the equality space and to think about sort of the contracting and structural enablers that can embed advancements in equalities in outcomes, access and experience for groups that are particularly vulnerable. So similarly, like with the PCREF steering group, we've mobilised a panel of experts by experience that are helping us shape an outcomes framework that has equalities very firmly embedded at its heart. I think the final point that I would like to, well, the final 2 points that I would like to raise, one is around data. I'm Australian, I say data. And we know that the quality and robustness of data in the IAPT dataset is good and can be used to inform all sorts of clever commissioning and things like that. But we know that in the round, the mental health services data set, the MHSDS, is quite immature and quite poor. So I think our focus and our plea is to continue to submit data to that data set, because once that is robust, then we can start to do clever things with that as well, including potentially looking into things like financial levers and other more direct things that we can do to support improvements in quality and outcomes for different groups with protected characteristics. And it's very difficult for us to do that when we don't have the data flowed. And then I think the final point that I would raise is that while it's not necessarily the sort of statutory function and focus of NHS England in improvement to look at training pipelines and things like that, we are working very closely as a programme with Health Education England on the diversifying the sort of training pipeline for people that work in mental health services, and also looking at the curriculum to give equalities a stronger focus, and that's an ongoing and quite longer term piece of work. And similarly, we're very closely linked with the team that are overseeing the Workforce Race Equality Standard, which was very much the inspiration for the Patient and Carers Race Equality Framework. So apologies, my neighbour is drilling into the wall. So yes, we're looking at mental health services and thinking about what we can do to support mental health services to sort of achieve the commitments of the RES, and looking at whether there's a role for us in sort of sharing and promoting positive practices that emerges there as well. And that's just a very quick whistle-stop tour of what's happening here at NHS England in improvement, but welcome any questions that people might have.
Thank you very much, Jono. So the first one, you're part of the mental health team, but are we right to assume that similar principles would apply to learning disability and autism, obviously?
So we work very closely with them at a national level, but the focus of the strategy at this stage is very much just on mental health services. And the reason for that being that a huge chunk of it, a good half of it, is focused on improving data quality improvements in the mental health services data set. But that said, it's not that we're completely cutting ourselves off from it, because of course we work very closely together.
Okay, thank you. And then a very pertinent question again, or comment. Will we see a more diverse group leading this type of conversation? Very aware that today, talking about inequalities, actually there's been quite a lot of white faces on the screen.
So yes, I agree with that, and that's obviously a challenge across the NHS. And I would say that I'm just speaking as one tiny person of a much wider task force that's chaired by Jackie Dyer, who's been appointed as Equalities Champion for the programme. What I'm saying here is not my thinking, it's definitely the collective voice of an incredibly diverse panel that we're very grateful to have on board supporting us with this.
All right, thank you very much. And then finally, there's an offer, I guess, to share some of our local good practice and experience, as we've heard this morning, with the national team, and potentially be able to influence some of the thinking.
Definitely. We're so hungry for any emerging positive practice or positive practice where it exists, and happy to sort of share that across the country.
Great. Thanks very much, Jono. Thanks for your time. We've got a couple of minutes left, and we wanted to just share some of the resources that are available. So James has just put a slide on the screen at the moment. Do you want to say a few words on that, James?
Yes, thanks, Olivia, and thank you to everyone for taking the time to attend on a Monday morning. I appreciate we've had around 60 people on the call, which has been great. Lots of new names, as well as names that we're sort of well associated with across our patch. So thank you so much to everyone for both for their contributions and also for attending. I was just going to briefly show you a rather it's not as snazzy nor full screened as I hoped, so apologies. I was going to see if that's more. Oh, there we go. Okay, great. So Jono was very helpful in setting out a number of resources that we've had. I don't know if Sarah's still on the call, but Sarah, from the work across EIP, I just wondered whether you also wanted to reference
the work
that you're also commissioning to support some inequalities work across EIP services.
Thanks, James, and thanks everyone. This has been, to me anyway, Monday mornings I drag, more so now that we're working from home, but this has been one of the most stimulating sessions I've attended. So thank you for everybody's participation and everybody's input. Just to say, early intervention in psychosis is a program that we hold dear and also take very seriously in the Southeast. The reason being that psychosis is one of the most stigmatized illnesses within mental health. So when you mention psychosis, people typically think of violence, or they switch off and can't deal with it. So one of the pieces of work we've been doing via the South East NHS England program is to unstigmatize that notion and ignorance. So we're trying to help our communities to learn that psychosis doesn't mean you're more violent or more prone to do stuff to other people. You're more likely to be a victim. So Olivia kindly put me in touch with colleagues in Sussex. So we're going to do a series of webinars where we invite people to just ask us about what psychosis is, and then we'll answer questions basically. Thanks, James.
No, thank you, Sarah. That's helpful. I know that we had a very brief email conversation, or I saw an email from you last week, so I thought it helpful to raise that. We're also looking at personality disorder across the South East as part of the community mental health transformation, and what that means, as a set of conditions, and therefore, how best we as a wider system can support conversations by learning from from peers and individuals with lived experience. So I hope that that's something that we will get moving. Anyway, just quickly, lots of information obviously from PHE. Across the South East we have Zaloni and Nisha. I'm sure there are other colleagues as well. They're doing some excellent work. They've just promoted they undertake a number of webinars which support the inequalities agenda, one of which is, I think, on Wednesday, around food poverty. So do stay connected or get connected to PHE as much as possible in this area. We've also got the psychological first aid training, which I believe has been a great success as it's gone out over the past couple of months. You'll see also the information which Jono was just mentioning, that we've got a number of profiling tools and co-production kits, as well as also from his conversation earlier, we've got a number of things that will be coming out over the next few weeks and months. The IAPT Positive Practice Guide is fantastic. Not only is it relevant for IAPT services, but it's relevant right across the board. So there's some really interesting points in that. And finally, something that came up from colleagues in our network, a very interesting report from Healthwatch Islington, which was, I think, came out at the start of this year, which really references a number of surveys that they undertook as a Healthwatch in London around what mental health means for migrant communities, and also how those migrant communities actually access support services. So I would encourage you to take a look at that. We've also done a summary which we'll forward out alongside the slides and the video. That's it, Olivia.
Thank you, James, and thank you, Sarah. So as a final comment, I guess, I would like to say thank you very much to all of our contributors, Louis, John, Pauline, Joe and Jono, along with James, who's coordinated all of this, and Sarah for your comments on psychosis at the end. You've all provided great insight as well as some practical suggestions in order for us all to think about how we can start addressing inequalities, especially for the cohort of people we try and support with either mental health, learning disability, autism, or a combination of some of these. I think one of the salient points was about the data. Know your data, collect it, analyse it, and that will be the starting point to change behaviours and practice. So thank you very much to all of you, and I hope you have a good Monday and a good rest of the week. Thanks.
Thanks, everyone.
Thank you.